So part C, let's talk about the pharmacology of treating sleep disorders and problems. There are 4 categories of medications, and these all fall under the broad heading of sedatives and hypnotics. There are benzodiazepines, barbiturates, melatonin agonists, and the non-benzodiazepine non-barbiturates. The sleep-wake cycle within the brain is a complex chemical interaction between many different compounds. Being awake, being alert, being ready to learn is a combination of the effects of dopamine, norepinephrine, and acetylcholine. Sleep and sleep induction is more related to serotonin. So the main uses of these medications are to improve sleep patterns for the temporary treatment of insomnia. We want to decrease the levels of anxiety and increase relaxation prior to the diagnostic and operative procedures. Barbiturates were first on the market back in 1903. And barbiturates were the main drug as a hypnotic sedative until about 1960, when the first benzodiazepine was developed and released. And after that, barbiturate use has greatly declined. Benzodiazepines, or benzos, are most commonly prescribed sedative and hypnotic agents, and one of the most commonly prescribed classes of drugs. This is directly attributed to the favorable side effects, their efficacy, and safety. Doctors will prescribe more medications that work without side effects. Barbiturates have many side effects. So let's look at a specific patient. You may actually treat a woman like this, a 72-year-old female who has not been sleeping well. She asks you about whether it's safe to take sleeping pills, and she's interested in pursuing this option so she can fall asleep at night. So what are we going to talk about? Well, we have some options. We have barbiturates, benzos, and the non-benzo, non-barbiturate. What are we going to suggest? What's important? Well, before we do anything, we always have to assess, right? You need to know more information. You can't just say, take this, because you might be right. You could very well be wrong. So we need a baseline. We always need baseline vital signs or baseline assessment before we start any treatment. That way you can assess whether the treatment worked or didn't work, if there are side effects or no side effects. So we also want to assess the sleep pattern. You know, how much do they sleep? How do they fall asleep? Some people fall asleep really easily but can't stay asleep. Other people can't fall asleep, but when they do, they're asleep in a deep sleep. Can they sleep the entire night? Can they wake up in the early morning, or do they not wake up in the early morning? And think of yourself. What's your sleep pattern? How do you sleep best? And are you able to fall asleep? Very likely, students have a hard time sleeping because they have a lot of schoolwork to do. They're anxious about school. They're anxious about work and school and family issues. A lot of things on their mind, and sometimes it can be very difficult to fall asleep. We will also assess environmental issues. What's the room temperature? The light situation? Is there noise? Is there no noise or too much noise? How about traffic patterns around the house? Do they snore? Do they drink caffeine? Caffeine can be a stimulant that will prevent falling asleep, especially taken later in the day. So, do they drink caffeine? And when do they drink it? And how much do they drink? We want to look at the respiratory status. Why is that? Well, think of the person who, when we talked about asthma, and they have a hard time breathing when they lay down. When you lay down, if you have a hard time breathing, that's going to cause that anxiety, which will prevent sleep. They also could be on medications for their asthma, such as the albuterol, the bronchodilators, which can raise heart rate and increase nervousness. So, hypnotics should be used when insomnia cannot be managed by other means. and drug therapy should be short-term, 2 or 3 weeks only. If you're on medications long-term, we need to find other ways of treating it. So let's talk about some medications. We're going to start off with barbiturates. Like I said, these are not used as often anymore. They are Schedule II medications, which indicate a very high level of addictive abilities. They can be habit-forming. They have many unwanted side effects, and they have a narrow therapeutic index. They reduce nerve impulses traveling to the cerebral cortex. They suppress REM sleep and stages 3 and 4. So is that what we want? Yes, you might be sleeping, but you're not in that deep, restful, restorative sleep. They're very rarely used. They can be used as anticonvulsants, such as phenobarbital, or Nembutal is the brand name for that. I've given phenobarbital to people with convulsive problems. I've never given a barbiturate for sleep in my career. That could just be my career. So they're considered prescription-only drugs because the potential of misuse and severe effects result if they are not used appropriately. They have a very wildly variable half-life from 3 hours to 180 hours. Very narrow therapeutic index, meaning, remember, therapeutic index, below it, nothing happens. Above it, bad things happen. And that's where it's effective. If a person has respiratory difficulties or severe liver disease, they probably will not be a candidate for barbiturates. So what are some of the side effects? Well, as with almost anything that causes hypnotic and sedative effects, it's going to cause CNS depression, drowsiness, potential lethargy, and headache. Hangover effects are common after administration of long-acting barbiturates with hypnotic doses. Patients may actually have a dulled affect, subtle distortion of mood and impaired coordination, blurred vision, and transient hypotension. And dulled affect, they don't appear to show emotion. The hangover effect is pronounced. Paradoxical responses in the elderly can cause excitement, euphoria, restlessness, and confusion. And people can develop tolerance to this very easily. So if a barbiturate will be used, it should be very short term, 2 weeks or less. There's also a rebound phenomenon. When using barbiturates, the proportion of REM sleep is increased, so after stopping it, the rebound effect causes more REM sleep, more time in REM sleep. So there's more chance for the vivid dreams and potentially nightmares. Other CNS depressants, of course, alcohol, antihistamines, opioid analgesics, other sedative and hypnotics, MAO inhibitors, and valproic acid. When we're using other CNS depressants, you should not use barbiturates because it will have a profound additive effect. So any of those CNS depressants, alcohol, antihistamines, opioid agonists, MAO inhibitors, valproic acid, no barbiturates with CNS depressants. You can develop physical and psychological dependence when you use barbiturates, and tolerance, as I mentioned, does develop. Rapid withdrawal can cause death. Barbiturates also have effects on other medications, so it reduces the effects of warfarin, theophylline, phenytoin, estrogens, beta-adrenergic blockers, doxycycline, antidepressants. Look at all the problems this medication can cause. This is why it's used so rarely. It can interfere with contraception. That's a major teaching point if you have a patient who will be taking that. So we have benzodiazepine receptor agonists. Fluazepam, temazepam, and triazolam. Some of the brand names: Dalmane, Restoril, and Haldane. And these were commonly used for sleep. In fact, when I was a new nurse, it was common practice to administer. We used more Restoril than anything else. We also used sometimes the Dalmane. So temazepam and fluazepam were the doctor's sleep. We call them sleepers of choice. We usually use Restoril about 10 o'clock every night for almost everyone. That was just standard practice back in the 90s at our hospital. Now, sleep agents are very rarely prescribed. So let's talk about some of these sedative hypnotics, the benzodiazepines. These are the most frequently prescribed drug for the treatment of sleep disorders. They should be only used for 2 to 4 weeks. It does not suppress REM sleep to the same extent that barbiturates do, but it may produce REM rebound after 3 or 4 weeks of use, which is why they are short-term only. They produce a depressing CNS effect based on potentiation or facilitation of the inhibitory activity of GABA. We talked about GABA earlier. Benzodiazepines, or benzos, you'll hear that phrase in the clinical setting. They have high lipid solubility, and most have metabolites that are also pharmacologically active, causing effects even after the plasma levels of the parent drug are undetectable. So you could do a lab draw and say there's no benzodiazepines, but why are they still sleepy? Because their metabolites have the similar effect, and those aren't the same as the benzodiazepine chemical. They each have different lipid and water solubilities, which influences their absorption, distribution, and transformation. Half-lives are variable, ranging from 2 hours in some to 150 hours for others. A half-life of 150 hours. 6 days. They're Schedule IV drugs, meaning low probability of dependence. They do increase total sleeping time, especially in stages 2 and 4. So they increase light sleep and deep sleep. They decrease the number of REM periods, but not as much as barbiturates. They do decrease total REM sleep, and REM sleep is very important. It crosses the placenta, enters fetal circulation. There may be an increase in birth defects. Do not give during the first trimester or while breastfeeding. They're very successful products from a therapeutic and safety standpoint. There's wide safety margins between therapeutic and lethal doses, so a wide therapeutic index. That's safe. Intentional and unintentional overdoses of several hundred times the normal therapeutic dose are well tolerated and not fatal. Imagine, several hundred times the normal dose, not fatal. There's many similarities between the benzodiazepines, but they are difficult to characterize as a class. So again, they decrease stage 3 and 4 sleep, and to a lesser extent REM sleep. There's some that have an amnesic effect, such as midazolam or Versed. Midazolam.